Good morning, everybody. I'm Sébastien from Safe Cluster. I'm very happy to host this webinar today. There are some good news and other news. The good news is that there are about 280 people, no, more than 380 people registered for this webinar, which is awesome. That's good news. So the bad news is that because of that, there is no option for you to open your camera or your microphone. Sorry for that. The good news is that wherever you are and whatever you are doing, nobody can see you on the screen. Obviously, there is an option for you to ask questions, and I invite you to do that through the chat window. This is a small window on the right of your screen. You can enlarge that as you wish. Probably you cannot see the question of all the attendees, but no worries, we'll see that, and our moderator will ask a question to the speakers today, or if we cannot address everything after this webinar. Last news, this webinar will last about 2 hours. I don't know if it's a good or bad news, but the good news is that we will do a short break right in the middle, a 5-minute break for a coffee. Thanks very much, everybody, for being there. That's a big community. And now it's really my pleasure to introduce Olga Vibornova from University Catholic of Louvain, who will start introducing this webinar. Enjoy the webinar.
Good morning, dear guests. I hope you can hear me and you can see me. It is my honor to introduce the topic of our today's webinar on just-in-time training. We are 5 networks of practitioners funded by the European Commission who are hosting and organizing this webinar. Namely, we are DAREnet, Inotis, FireIn, Medea, No Fear networks of practitioners. Initially, just to date back a little bit in the history, we planned to organize a joint workshop at Interschutz Fair in Hanover in Germany, but due to the crisis, all large events were cancelled. Interschutz was cancelled as well, and it is postponed to next year. So still we decided to organize jointly a virtual event on the topic which is relevant for all our networks of practitioners, and we believe for all our guests. And this topic is emergency training of first responders just in time for the crisis response. Basically, during the crisis situation, there is no time for normal long training. And then it is important to deliver this just-in-time training, meaning the right material in the right educational modality to the learner at the right time, at the right location, and exactly in the needed amount. And it corresponds to the golden educational rules and values, meaning to deliver the greatest amount of educational content in the shortest amount of time. We need to remember that, of course, just-in-time training is never generic. It is always specific to a particular crisis or incident at hand. It is delivered usually to first responders to learn some new task or new procedures or use of equipment or safety and security in the conditions according to the specific type and scale of the crisis or incident. Of course, just-in-time training cannot replace normal training. It is delivered as a complement. Not always, but very often, first responders of one discipline are trained for new skills in another discipline in order to compensate for shortage of experts in the relevant field during the crisis response. And then it is interdisciplinary education, interprofessional education. And then we believe that this is the combination of the regular training and additional knowledge acquired in just-in-time training that really amplifies the result. I'm sure that all members of our 5 networks of practitioners and all invited guests, all of you, have plenty of examples of such just-in-time training from your practices. On our side, we also have some, and I would like to share a couple of quick examples. The first one comes from our lab, where I'm working, Center for Applied Molecular Technologies, Université Catholique de Louvain in Belgium. In cooperation with Belgian Civil Protection, we delivered training to lab staff and to external volunteers, external experts for collecting and analyzing COVID-19 samples using the laboratory materials and equipment. And now our mobile laboratory is deployed for a humanitarian mission in Italy, in the Piedmont region. This mission is led by Professor Jean-Luc Galin. This mission is meant for 2 months. And this mission supports the local civil protection and local hospital in Piedmont region. Another example comes from Fire and Rescue Service of Seine-et-Marne in France, where firefighters were trained for deployment in field structures to support hospitals, for deployment of in retirement homes. And here again, we have to remember that this additional training for the COVID-19 crisis was possible quickly and efficiently due to already previous knowledge and very substantial training of firefighters of dealing with infectious diseases and their general CBRN culture. They, for example, already knew the core principles of contamination management and things like that. So that's why they adapted very quickly and they were able to learn very quickly. And one more example, interesting example of new learners, just in time, were that Seine-et-Marne firefighters train 5 shepherd dogs to sniff COVID-19. These dogs have already experience in identifying cattle sick with other diseases, and now they are trained to smell coronavirus. So they are trained on the hospital samples from COVID-19 positive patients. These samples are put in containers, and there are already some positive results. So dogs are able to identify the right samples with COVID-19 and the right containers. Of course, more tests are needed to avoid false negative results. During today, you will hear in detail more detailed presentations about more examples of just-in-time training in the COVID-19 pandemics from No Fear project, for flood response from DAREnet project, and from in CBRN field online learning from eNotice project. Here are the contacts of our 5 projects, generic contacts, and always you are welcome to contact us at any time for discussion. We are always happy to receive new members, new stakeholders, and we are always very enthusiastic for this. Now we would like to proceed with presenting you our projects, and I invite DAREnet to start.
Yes, thanks, Olga. So this is Chris Illing. I'm with the THW in Germany, and we are coordinating the DAREnet project, which is not a typical research and development project, as you probably know. It's a coordination support action, same for all the others. It's a network project. We try to gather the knowledge from various stakeholders in the field of flood protection, flood management, from the Danube River region. So we have formed a consortium of 15 partners representing 11 countries. Yeah, we're setting up this large community and exchange on practitioner needs, search for innovation opportunities, and formulate that in a roadmap, which hopefully will then be picked up by decision makers and will guide industry also to new and promising solutions. And obviously, while dealing with floods in the past, has always involved some spontaneous volunteer involvement, and this requires a lot of then just-in-time training, because you never know who will show up and what they will do, and we will have a speaker presenting his experience in that field later on. Thanks, and I will hand over to the next.
Thanks, Christian. So firing, Sebastian Ayer again, so the coordinator of this firing project. As Christian already said, our project are projects of networks, and our focus in firing is the fire and rescue community in Europe. The objective is definitely to strengthen the fire and rescue capability in research and innovation in Europe with a bottom-up approach, just to express correctly the needs of the practitioners. We work with 5 thematic working groups. The first one is about search, rescue, and emergency medical services. The second thematic working group is on structural fires. The third one is on landscape fires. The fourth on the other natural hazards. And the fifth one with CBRN events. And you can find everything on www.firein.eu with this nice platform with hundreds of practitioners engaged there. Thank you for your attention.
Good morning, everyone. My name is Monica, and I'm here as I am part of the coordinators team of the No Fear project. The No Fear project is a network of practitioners that brings together practitioners, suppliers, policymakers, and researchers in the field of emergency medicine. The aim of this project is to enhance the collaboration and the cooperation among different sectors. As I said, we put together suppliers and practitioners, policymakers and researchers. And in this way to overcome, or at least try to overcome, the fragmentation that exists in the field of emergency medicine, and try to improve the response of the emergency medical system to the new threats. This year for our project was a big deal because the biggest health threat came to us, and as a project we had a huge role in trying our best to in some way enhance, amplify the collaboration within the European landscape to the response to the COVID-19. One of the examples is the work we did in the training that will be well explained later by my colleague here. Thank you and see you later.
And now,
good morning.
Sorry, Enotis now.
Okay.
Me again with a presentation of Enotis project, which is the European network of CBRN training centers. And our objectives in this project are multifold. First, we decided to find and map all the existing training centers in the European Union. Currently, we identified 202 training centers, and 47 of training centers joined our network. And these training centers who joined the network, they are primarily from the European Union, but a few of them come from outside European Union. If you go to our website and look in the catalog, you will discover 3 training centers outside European Union. That is due to our collaboration with DigiDevco. DigiDevco also has an objective to map training capacities, but outside European Union, and they offered us to unite the efforts and to use our questionnaire, our methodology in order to approach training centers. So, okay, we have the collaboration with them, and training centers from outside European Union can also see and have access to European Union training centers. Then our main networking mechanism is organization of multiple joint activities, meaning field exercises, tabletops, serious gaming, and simulations throughout the project. And all of these exercises are not organized specifically by the project, but they are hosted by member training centers who open their normal annual exercises and invite other stakeholders, current R&D projects to our exercises. We have in our consortium 7 civilian training centers and 3 military training centers from 8 countries. And we work with many research and development projects who actually participate in our exercises. There are some observers, but some actual participants. For example, terrific project, current CBRN projects from CBRN cluster part B. And another one, it is a current CBRN project proactive. So the major distinguishing points of a notice is this multidisciplinary exercises, what we do, civil-military cooperation, which is very relevant in CBRN field, and cross-border exercises. You can see pictures from a couple of examples, an exercise in France, and German-Polish exercise in Germany, in Dortmund. So you are very welcome to visit the website and get more information about our network of practitioners. Next one.
Good morning from me. Warm welcome on behalf of the Medea Network of Practitioners. Medea is a regional and practical, it's a regional network of practitioners and made from members from the Mediterranean and Black Sea region. We are a multidisciplinary network of security organizations, and we have a variety of expertise coming from various organizations like police forces, search and rescue team, and humanitarian workers. A variety of first responders with having one thing in common. The organizations are based in the Mediterranean and Black Sea region. This is why we're using this community of practice model, where we bring together practitioners with focus areas on migration and asylum seeking challenges. That means organizations varying from border guards, police officers, personnel from various governmental authorities, NGOs, to name but a few. Likewise, we have practitioners and stakeholders from national and EU organizations supporting operations at EU borders. Also, we have to mention the community of practitioners. We are challenged to respond to cross-border crime, return of foreign fighters, and new form of terrorism. Last but not least, we have a community of first responders who have to deal with the consequences of natural disasters, technological accidents, and quite often a combination of them. So, Medea objective is to join forces with practitioners from other networks, like we're doing this time, and a part of defining and prioritizing common capability gaps, we also looking to outreach solutions providers and engage with them into a fruitful dialogue that will lead to more secure societies. That's it for me, and I hope you find this webinar applicable and interesting. Thank you.
Monica here again. I'm very pleased to introduce our first speaker, Dr. Luca Ragazzoni. Luca is the scientific coordinator of CRIMEDIM Research Center in Emergency and Disaster Medicine. CRIMEDIM is a research center based in Italy with projects worldwide, both on research and operations in the field of disaster medicine and humanitarian aid. Luca has more than 15 years of experience in designing and delivering training both for professionals and for the academia field. During the Ebola outbreak, Luca had the opportunity to be a training manager for a very big project run by Save the Children, where more than 1,000 healthcare professionals were trained using innovative technologies. And this gave him the opportunity to be in some way ready to take care of the training of the healthcare personnel in our hospital in Novara during the COVID-19 crisis. I don't steal you more time. I leave the floor to Luca for his presentation.
Good morning, everyone. It's a real pleasure for me for being here, and I would like to thank the organizer for inviting me. I will give you a brief explanation of what we have done in Italy, in the Novara hospital, the second largest hospital in the Piedmont region, and I will also give an example on how to use innovative solution for training healthcare workers all over the world. As you know, the COVID-19 pandemic is currently treating numerous health systems around the world, requiring an extraordinary international response to contain and control the virus. These are the numbers from yesterday, and as you can see, we have more than 8 million cases all over the world. This response includes effective education and training of healthcare workers to attain several operational level public health skills. Normally, these skills are beyond the experience and knowledge base of most practitioners, not familiar with the public health emergencies arising from infectious disease outbreak. As already said, Italy has been one of the most affected countries where hospitals were struggling to deal with the surge of patients affected by COVID-19. Patients were being treated in hospital corridors. Hospital departments have been converted to treat only COVID-19 patients. Many physicians and nurses were working outside of their field of expertise, feel uneasy managing and treating a highly transmissible infection for which there is no specific therapy and no vaccine. Moreover, the risk of secondary infection among healthcare workers is extremely high. In such context, we believe that implementation of just-in-time training intervention focused on population-based medicine and management skills was of paramount importance to equip health workers with basic competencies to proficiently and safely work in any hospital and pre-hospital services during this current pandemic. Just-in-time training is a well-established concept, as I already said at the beginning, mainly among disaster and humanitarian responder, and is intended to rapidly address specific information, tasks, skills, and knowledge just before the deployment to a disaster-stricken area, and also to prepare provider for the deployment experience and to maximize the effectiveness of disaster response. The Novara Hospital, as I said, is the second largest third-level referral hospital of the Piedmont region, one of the most affected regions in the Northwest Italy. So while COVID-19 was rapidly spreading in the region, the activation of the hospital contingency plan for massive influx of patients progressively established the transformation of hospital wards and sometimes also asile into cohort intensive and non-intensive care units for COVID-19 positive patients. At the peak of their mission, the emergency department and the ICU expanded their operational staff and structure, so the main aspect of surge capacity, and more than 200 COVID-19 beds were made available, and more than 300 healthcare workers were asked to change their roles and tasked to equip these newly opened hospital units. In this scenario, we recognize that a COVID-19 just-in-time training was essential for the entire hospital to meet the needs of rapidly attaining competencies that were beyond the experience of most of them. Furthermore, we strongly believe that the unexpected magnitude of this crisis generated a requirement that will require not only the attainment of infection prevention and control measure and public health skills that of course are the core of outbreak and population-based management, but also the awareness of disaster medicine principles such as surge capacity and scarce resource allocation, triage, and how to deal with ethical dilemmas of rationing medical care. So therefore, we designed the COVID-19 just-in-time training to provide the entire hospital healthcare workforce with a common background, competencies, and proper attitude needed to proficiently and safely work inside the hospital during the COVID-19 pandemic, understand the working principle and the standard operating procedure in place in the hospital, accurately apply and remove the personal protective equipment, as you can see in this picture, and as I said, understand the principle of disaster medicine and public health emergencies applied to the COVID-19 pandemic. In this table, you can see the curriculum framework of our just-in-time training implemented in the hospital. At the end of the training, the participant met the needs of hospitals seeking of qualified hospital-based healthcare personnel with basic IPC competencies and awareness of disaster medicine, ready to respond to the COVID-19. The utmost learning objective was to practically improve the public health management component and awareness and technical and attitudinal performances rather than delivering the mere knowledge. So we ran the training every afternoon for 3 weeks from March 9, and we trained around 200-300 hospital staff. The training lasts 4 hours, so as you can see, it's very short and just in time. And every training session was opened for a maximum of 30 healthcare workers, hosted in a main hospital conference hall with around 100 seats to ensure social distancing. So given the strong traditional public health measure and in place as of the lockdown, e-learning has been the favorite training methodology worldwide. However, taking the proper precaution as the social distancing and safety measure, we decide to use a classroom-based approach to ensure that participants could really approach and practice the application of PPE, donning and doffing, and especially to discuss any possible doubts directly with us. So to understand the issue within the hospital and to solve it. However, an e-learning session was made available by everyone in the e-learning platform. So on June 15, so after 4 months since the beginning of the outbreak in Italy, more than 20,000 Italian healthcare workers contracted COVID-19, and unfortunately, more than 160 have died. So this number reinforced once again how important was the implementation of the training to address competencies that we knew were beyond the experience of most of our colleagues. Another lesson learned is that the idea to address disaster medicine and population-based management concept was also crucial, taking into consideration that the rapid spread and insurgence of COVID-19 pushed to the limit the hospital contingency plan, generating a crisis management condition that collapses all measured public health protection. And for the majority of the healthcare workers in the hospital, this was their first experience in responding to a large-scale public health emergency or a disaster. Regrettably, public health emergency and disaster medicine or global health, most of them are never studied in the medical school. So our intention is that the current pandemic should stimulate the academic community to consider introducing at least some basic disaster medicine and global health teaching in the medical and nursing school. Then we use our experience in developing virtual reality training to train healthcare workers around the world together with the NGO UK Met. So our previous experience during the response to the Ebola outbreak in 2014-15 in the West Africa, at that time we applied an innovative just-in-time training methodology using virtual reality simulation. At that time we demonstrate that virtual reality is effective to increase staff safety before taking the risk on working within an Ebola treatment center. Unfortunately, the rapid insurgence and spread of COVID-19 in northern Italy implied that the urgency to train the hospital staff in a matter of days, impeding us to devote time in computer programming to develop the virtual reality scenario. But as I said, now we have a scenario, and now we are using and disseminating the online virtual reality simulation all over the world, especially in low resource settings. So why virtual reality? Virtual reality simulates highly specialized real world environment. Training can be done remotely, and I will show you later, ensuring access to a high number of staff. Safe training, of course, for a high-risk scenario as Ebola and the COVID-19. Increased knowledge retention because you can repeat the scenario more time. Reduce the cost and travel and during the travel restriction. And you can use virtual reality with other type of simulation, developing hybrid scenarios. And since it's very flexible, you can be adaptable to different contexts. In this case, during the COVID-19, we worked together again with the WHO, the UK Met, to create a virtual reality scenario that expose humanitarian workers in understanding a community center layout, a COVID-19 community center layout. As you know, at this moment, it's very important to create a community center in countries where there is no capacity to admit and treat patients. And basically, using the 2D layout, we develop a scenario. And from this video, you can see how the humanitarian workers and all the healthcare professionals and all the professionals that are working within a new community health center can understand the working principles and layout working within the center itself. This is the entrance of the community center layout. And as you can see from this video, It's very important during the triage to use plexiglass or a screen to avoid the contact with suspected cases. And then, of course, we created in a virtual reality scenario the entire community center, also where the patients are really treated. And from this video, you can see how can you, the trainee and attendee, can walk in and again understand the standard operating procedure and the working principle and the safety measure within the community center. So this is what I wanted to say, and thank you very much again for the invitation. And these are my email address if anyone can contact me later on. Thank you very much.
Thank you very much, Luca, for your interesting presentation. I think it was very valuable to hear the experience of someone who found himself in one of the worst hidden areas in the world, at least in the very first weeks. So we already have some questions, and we have now 15 minutes to answer to all your curiosities. Feel free to post them on the question box. We have already Damien from Switzerland asking Luca, how did you form all the healthcare workers that needed to change units? For example, pediatric nurse to work in ICU, because here in Switzerland, nurses had only 1 day of supervision to learn ventilation basis, etc. Luca, can you give an answer to Damien?
Yeah, so I would like to specify that, so the just-in-time training that we implemented was not for training or equipping healthcare workers to change the role, but was a very short, again, 4 hours course to equip them with basic principle of infection prevention and control measure, again, disaster medicine concept, and standard operating procedure policy within the hospital. Yes, of course, and the healthcare workers that shift from one department to another, what we did, we suggested, and for example, in the ICU, we did it. So we created a mentorship process where we flanked highly experienced ICU staff with no experience one for a 10 days apprenticeship process. And of course, after these 4 hours, and we added the apprenticeship process while working in daily.
Thank you, Luca. Damien, I hope you are satisfied with this answer. Then we have Anne asking if the virtual reality training is available in several languages.
So there is no languages. So basically, we created the scenario and we created different videos to expose health professional in understanding the layout. We use the software that are available on market. We don't own the software. Basically, we use a software already available, and we use our experience in developing training using virtual reality for this specific task. Our scenario is totally available. If you need it, I can share with all of you that are attending now the scenario, but my suggestion is that should be adaptable to the needs, to what you want to achieve. So our intention was to expose professional before the deployment in the area to understand the layout of a new COVID-19 community center. So because one of the most important part for a new health professional entering a new working place is to understand where there is the triage area and which kind of personal protective equipment I need to wear in that specific area and which are the measures in place. And again, so the virtual reality gives us the opportunity to explain how to move and where you have to behave in a certain way.
Great, thank you very much. We have a question from George from Romania. George is asking, how did the hospital workers react to the just-in-time training, and did they find it useful?
So we have just published it in one of the most important journal for academic research, education and training research, is the academic journal, academic medicine, sorry. And unfortunately, as we all explained also in the paper, we were not able to assess outcome or to evaluate the effectiveness or the satisfaction of the participants, because we decide from the beginning not to add the workload to the participants, and because a lot of literature already say that just-in-time training is very effective. But yes, we have some lesson learned, as I said. The training was really appreciated. The feeling that we had while we were running the training, that the just-in-time training was highly appreciated, because they solved a lot of doubts. And then the other issue is that most of the healthcare workers working in our hospital, again, they never experienced a crisis like that and a disaster like that. So explaining our previous experience in Ebola, in Haiti, and our experience in disaster medicine was really important for them to understand, to sensitize the healthcare workers of the importance to be available, to increase the willingness to respond, and also to give them the confidence, the right confidence to respond. And then most of them after the training were ready, and the fear disappeared. This, in my opinion, was the key of the training.
Thank you very much. A couple of questions more for Luca. Solara is asking, how many days after the COVID-19 cases started to appear in Italy, the training was conducted?
We started right away. So we started the day after we had the first cases, actually the same day. So we started in the ICU and in the emergency department, and we started in parallel with the creation of the standard operating procedure and the patient flow. Okay, so we brought our experience from Ebola in the hospital, and we created patient flows for suspected and not suspected cases, and also patient flow for staff, where to create a one-way entrance to the ICU and to the emergency department to avoid contamination. So from there, we expanded, after 1 week, we expanded this training to the whole healthcare workers of the hospital, moving the training from the ICU, a small room of the ICU, to the, as I said, in the main hall of the hospital, with a lot of seats, but only for 13 health professionals a day, so to maintain social distancing. And so we were able to start right away, and we ran the training for 3 weeks until we haven't any attendees anymore.
Thank you very much, Luca. Then we have quite a good group of people asking about something similar being organized in low resource countries. Muhammad, for example, is asking if it is possible to conduct such trainings to public health clients, for example, the Ministry of Health outside EU, and other attendees are asking if there is any plan to deliver similar trainings outside Italy, in low-resource countries in particular. Luca.
Yes, so as a research center, as academic research center, we are working with many organizations, international organizations as UN, WHO, and also non-governmental organizations. As I said, now we are working mainly with UK Med and with QAM. And so we are supporting them for this training. And this training, the virtual reality training, has been used by UK Med for all their staff. And their staff, they are using the training in countries for the local, Ministry of Health and local healthcare workers in several countries. And with QAM, we have a large program in Sierra Leone. We are partnering with Africa QAM, and we started a large program 3 years ago, and with the objective to implement the emergency medical service, the ambulance service throughout the country, a national service. And before COVID arrived in Sierra Leone, we trained all the paramedics and drivers to manage COVID-19 patients outside the hospital.
Thank you very much. If I have time, I would like to pose 2 more questions to Luca. One is concerning the virtual reality scenario. Ivana is asking if there is no language interaction, did you identify needs for incorporating language interaction in the tool at a certain point?
Yes, of course. So what we did, for example, during the Ebola, we used the virtual reality scenario in Sierra Leone. And at that time, we trained the trainers. We trained local trainers in using the tool and the scenario to train the others. So my suggestion is using the virtual reality at your needs, okay, and not having a generic virtual reality scenario. Of course, we can do that, but it should be in English. Otherwise, it's difficult to translate the voiceover on the virtual reality in many languages. I would suggest to use the scenario and adapt the scenario, embedding your voiceover or your slides in what you need.
Okay, thank you. And a few people, as per the face-to-face experiences, they asked if you received any feedback from the virtual reality training, and how was the feedback of the users in this?
Okay, for the COVID-19, we have been using only by a distance, so we are scheduling online training for UK Med staff every week, and we normally have 20-30 participants every week, and they appreciate the fact that they now understand before the deployment how a new COVID-19 community center works, because it's different seeing the COVID-19 community center layout in a 2D map rather than seeing in a 3D in a virtual reality and walking. So again, as professional, the most important part is to feel comfortable, to understand where there is the risk and how to protect themselves from the risk.
Great, this is clear. I am afraid we finished our available time for question and answers. Feel free to reach Luca at this address if you have any other questions about this. And I leave now the floor to Sebastian.
Thanks very much, Monica, and thanks very much, Luca, for this brilliant presentation and discussion. Now it's time before to hear and see our next speakers for a few minutes breaks. So just for 5 minutes, very maximum, to have a coffee. Thanks everybody, and be back in 5 minutes. Okay, I guess the coffee is good, or tea maybe. Now it's time to move to our second very exciting presentation. And may I invite Christian to introduce our next speaker. Thanks.
Yes, thanks. So I'm glad to introduce to you Jolt Killerman, who is the current head of the EUSDR Priority Area 5 Disaster Management Working Group. It was a regional policy body, but his background is pretty strong in firefighting, since he has been in that profession for many years. Prior, he was a trained mathematician. Since 2020, Jolt is head of this disaster management working group for the European Union strategy for the Danube region in the priority area 5 on environmental risks. Further, Jolt is the vice president of the Hungarian Firefighters Association since 2008, and also the president of the local Budapest Firefighters Association since 2012. Additionally, he is a board member of the Fire Safety Advisory Board within the Ministry of Interior in Hungary since 2016, and very interesting to us, and pretty much joining with the topic of this day's webinar. He's also the current project coordinator of the Interreg project, joint development of the voluntary emergency response and disaster management capacity in the eligible border area. So I'm glad to hand over to you, Jolt. Looking forward to your talk.
It's nice to see you, Christian, live, if not in person. And welcome everyone to this webinar. First of all, I'd like to add that our hearts and minds go out to the Italian medical staff for what they've been doing in the last 3 to 4 months, which is enormous. We will connect in my presentation. We might be able to connect to one part in just-in-time training to the previous presenter. I have started sharing my screen. I don't know if you see it properly. That's the opening screen. DAREnet has already presented what they wish to. Lessons learned from past and recent disaster incidents. This is my topic, with a special request to focus on the floods, which we had quite many, and the latest and the largest was the Danube Flood in 2013, where the Danube at Budapest peaked at its ever highest, almost 9 meters. This is not really much telling to anyone other than those living in Budapest, but if you see that's the lower bank, Parliament in the background, and even the upper bank had to be protected at some point. What concerns this training issue here is how can we engage volunteers in major scale incidents, in this case floods. The concept of engaging volunteers, and we have to make a few distinctions here, but before going into that, the training that has to be given to anyone showing up on the scene has to be clarified in advance, and this would also concern in our minds. We would also train media workers as well. We had initiatives and we have compiled materials for them. This has not gone into operation yet, but let's hope it will someday. So the idea is to provide trained first responders and engage third parties with, and the keyword, situation specific and relevant safety and security guidelines on the spot, or preferably in advance, And first, I would like to clarify the target groups. Trained first responders are two categories to me. One is carrier. In many documents and pieces of legislation, they call them professional first responders. And I would like to make a very clear distinction here. And this is the US term carrier, meaning those who are paid for their work, as opposed to volunteers who are not, but hopefully they live up to and work according to the same standards of their profession or their vocation. So this is important because if you say professional and volunteer, then volunteers sound like amateurs, which they are definitely not. Engaged third parties are those who first responders, even at the scene of a road accident, can be engaged to help if you need their manpower or even their tools or vehicles, whatever they have. Engaged third parties could be carrier practitioners, public utilities, industrial or technological foremen in different facilities. And as in the case of a major flood event, it's spontaneous volunteers. And they all have to be given this, the trained first responders usually are given a briefing, orientation. Engaged third parties need a bit more. How about in advance and on the spot? It's preferable to receive information before going to the scene of an incident or accident, as opposed to on the spot. So even with the Danube flood, we try to give information to spontaneous volunteers before they arrived to their place of engagement. The in advance part could be done through individual learning, any documents handed out, but preferably some sort of internet, web-based or even mobile application-based pieces of knowledge. On the spot is pretty much the last stage where just-in-time training or any information could be given to those entering either the work zone or in more dangerous situations, it's the danger zone. On this small picture, you see the bottom right corner, big, I think it was an A3 or A2 size poster with many information concerning spontaneous and trained volunteers. I have a question mark here with the verification. I was going to ask that from Luca, but I figured I can touch upon this in a more general fashion, that it's nice to give people information and knowledge, and we always assume that, okay, they paid attention or read what they were supposed to, did what they were supposed to, and they know all that is written or was given in any other form. How do we know that? We just take this for granted. That's why I would prefer methods of e-learning, or at least something technologically based, which could be a mobile phone, where we can have at least a few questions, which especially spontaneous volunteers and engaged third parties give a feedback on what they understood from what we were trying to tell them. The in advance part here at the Danube flood in the capital in Budapest, the disaster management directorate opened a surface, and that is seen at the bottom left corner, a registration form where any spontaneous volunteer who wished to come and help did not just show up on the scene uninvited, quote unquote, but they had to register for 2-hour shifts. So this way, the workforce, the spontaneous volunteer workforce could be distributed evenly, another mathematical term, and they could be given some information in advance. Hopefully, in the future, this might be and this is the Interreg project, which Christian has mentioned, that we are developing a mobile application for trained first responders, especially volunteers in the Carpathian Basin, scalable up to 50,000 volunteers, where a mobile app can notify those who are part of this pool, and they can register for specific events, which could be incidents, could be trainings, training courses, could be social events, and anything else, even summer camps, at a quick click of a button. On the right hand side, you see this 22 points of what to do in case of a flood, the rules of working. This is what it says at the top. Even the workloads, which is not too, how would I put it, not really equal opportunities, because it says that male volunteers can lift weights, loads of up to 20 kilograms, whereas female volunteers could not do that, but that is really not lifelike. In the future, it would be nice to have, first of all, we try to focus on the Carpathian Basin, the Danube region, but hopefully at the European level, and not just EU level, but European level, we could have standardized training materials for carrier and volunteer trained professionals, trained first responders, and we could have just-in-time training modules which are incident or event specific, and those could be shared with spontaneous volunteers and third parties in general. And the Disaster Management Working Group is aiming to be a platform for this knowledge sharing. And of course, we would like to identify good practices in the various European countries, and not standardizing everything, but focusing on recommending, harmonizing these practices and procedures and protocols. On the right hand side, you already see this mobile app, which is an event manager. It's downloadable from how would I say, neutrally, the various mobile applications, mobile platforms. This is a closed system, so it's not open for anybody, but we authorize registrations to this mobile app, this event manager, where the trained volunteers will be notified of various events. And we also aim, which is very important, to keep a record of their competencies and skills, which I would regard as a higher level of knowledge as opposed to competencies. Skills which can be readily applied if needed. By this I mean the driver's licenses for different categories, even with vehicles with sirens, or the medical examinations when they expire. So we would see on this platform right away who can be engaged or deployed to a major incident. We could see if they have special equipment training with examinations, and I would say valid medical examinations, which are in Hungary are for 2 years or 3, depending on the age group. For chainsaws, high capacity pumps, electric poles, transformers, spreader cutters, whatever. So this is what we are aiming at. I don't know if I'm within my time limit. Yes, it seems. Just another picture, and this is the verification bit. We do some work for a big electricity provider, and by me, big, I mean it's a national one for the service providers. And every time we enter a facility, we have to sign different sheets. One of them is a work safety log, where we attest that we understood the just-in-time training, the on-the-spot training for that particular facility, where we can go and where we should not go. This is important in how would I phrase, in unwelcome events when something goes wrong. Usually the person or the people responsible will be held accounted. And if there is a signature that they were given instructions on what to do and what not, this responsibility might be narrowed down. For example, as engaged third parties, a few years ago we had to cut out some dangerous trees near a children's railway, where we had to engage the operators of the railway. They came with a locomotive, they brought their own equipment, we had to work together. Everybody was told what they could do on the scene, how to pay attention to one another, who is in charge and who has to be looked at all the time. And I see that there's something wrong with my webcam, but I don't know how that happened. It's green on my control panel. So everybody was given instructions for working together, and they each and everyone had to sign that they understood what's going to happen. This narrows down the responsibility of the person in charge on the scene, on the spot. It will not eliminate this totally, but it helps to a certain extent. And there is, I mentioned this to Christian when we were preparing for this presentation, that, for example, in the Hungarian nuclear power plant, this work safety log works electronically. You have a touch screen and 10 questions are asked. If you just make one or two mistakes, I think you are allowed to enter. Well, this means for daily, not the employees, but those contractors, subcontractors coming in to perform some work. And if they fail more than that, they cannot enter the facility. So that's pretty much verification. And this is something we have to keep in mind, how we can verify normal forms of training or e-learning, whether they acquired what we wanted them to acquire, and especially in case of just-in-time training, how do we follow up on whether everybody understood what we were trying to get through. Thank you for your attention. I'm open for questions.
Thank you, Joel. And indeed, we got some questions. Let me start with one. So there's one. There's one. I would call it general comment on the verification and batching and controlling the admission of volunteers to the scene, to stay on top of the situation. And what's your obviously your opinion on that, but that goes kind of hand in hand with a question if whether paramedics trained in other countries would be eligible for spontaneous volunteers. I think that highly depends on the local law situation or national law situation, but I would like to hand over to you if you have any of that experiences, like experts from other countries trying to bring in
for example, with the Danube Flood, and just recently we had big storms last year. We have fellow firefighters, volunteer and carry firefighters coming to help in case of bigger incidents. Generally, what happens, how can you engage somebody from elsewhere? Obviously, there is the EU civil protection mechanism, but that is strictly controlled by state agencies. But volunteer organizations, for example, our firefighter association can invite fellow firefighter association members. And the way this works is, with any incident, there must be a carrier firefighter, carrier civil protection specialist on the scene, and everybody reports to this person. So do the volunteers, and they do not do that individually, but the chief or the commander of the volunteer firefighters, or deputy commander of the volunteer firefighter reports, and the volunteers report to their own chief or deputy chief. When we invite or receive help from outside the country, they are as if they were our own volunteers within the volunteer fire brigade, and this way the chain of command stays, and with the implications of liability, responsibility, as I already mentioned before. So, for example, an EMT coming from abroad will be considered as a volunteer, not a spontaneous volunteer. If he can prove his qualifications, he will be qualified as a trained volunteer, and we will be aware of his competencies and skills, hopefully. We are working towards having an ID card, which would be a smart card, and everybody could show it up on the scene, either that's a major incident or a minor one, and the on the scene chief could read that smart card and see whether that person is actually eligible to use a certain tool. Because it did happen in the past that somebody was using a tool he or she was not trained to, and even if he or she is trained to, she or he might have an expired medical examination. Until something goes wrong, this seems perfectly fine, but when the foot hits the sham, as the Americans say, this chain of responsibility will be unwinded.
Yeah. Thank you. I think that was answered. Then we have some questions regarding the technological questions regarding the mobile app. Are you considering to incorporate the verification function in the app? And then what are you thinking of?
This mobile app is for trained volunteers. Their training is shifting towards e-learning, distance learning formats as much as possible, as Luca mentioned, to save time and other resources. For example, save time of the instructors, save which costs money eventually, and save fuel, save travel time whatsoever. So we try to, we have 40, 80, 120, 140, 200, 300, 600 hour courses. We try to narrow down these times at least to 50% or even lower if possible by distance learning forms. At the end of each of these training courses, they will have to pass an exam, which we will be aware that they have passed. We can enter this to the database behind the mobile app, because when there's, for example, a storm, we want to know how many people are trained to use chainsaws, for example, or work in at height. We will know that from the database, and we will have the opportunity to issue alerts or deployment requests to only those with the qualifications, or with the alert we say that we are expecting people with these qualifications, and then we can check. The verification therefore is done through the e-learning platform, but when it comes to spontaneous volunteers, I think it will be through the registration surface, which is probably web-based. And I would have 10 questions or 20 questions at the very end, so they would be able to provide feedback.
Okay. So there was maybe a quick answer. How do you ensure the actuality or the up-to-date, that the data is up to date in the app or the application?
In the mobile app, the heads of the volunteer units manage their own staff. So it's their responsibility. It is their responsibility right now. It's just Excel sheet and paper formats right now that they have to provide the National Association of Firefighters, the Hungarian Firefighters Association, with valid data, because this is a precondition for their insurance. The Hungarian Ministry of Interior covers volunteer firefighters with the same insurance policy as it does the carrier firefighters. But the condition for being part of this pool of volunteer firefighters, insured volunteer firefighters, is to provide valid and up-to-date data.
Okay, thanks. And we have a couple of more questions. I think we might have time for two more. If one is going into the direction that the credential process and who's performing that, who's which agency is responsible, and who's managing the volunteers? Is it just the firefighter organization, or is it or are there other stakeholders as well who
I know in neighboring countries, most neighboring countries, is the firefighters associations organizing the training courses and the examinations. In Hungary, we are allowed to organize training courses and take part in the training, the instructing of new volunteers, but the examinations are held by a body of examiners delegated by the state agency, the Hungarian Disaster Management Directorate in the particular county or one of their branch offices. That's how it is done. So it is. We have for this is for the volunteer firefighter trainings, different stages, but the use of equipment, we have a special blue book, a small one, which is identical to the carrier firefighters, and those training courses are the exact same thing, and with the same seals, stamps, same types, even for sky lifts and engines. That's why I made this important distinction at the very beginning, that I prefer the term carrier as opposed to professional for the paid firefighters, the paid EMTs, and the volunteer would not mean amateur, because these are the same exact qualifications.
One last question then. How do you address the problem of acceptance related to spontaneous forces among the trained or the professional first responders?
Could you rephrase that?
Have you experienced any issues in the acceptance of spontaneous volunteers, spontaneous forces, being that the professional first responders are offended or have problems to accept?
I think that this one is concerning the trained volunteers. Spontaneous volunteers can enter certain work zones. They cannot even enter danger zones. Work zones they can enter when they are needed, and as much as they are needed for in case of floods. But even during the flood, there were zones which only carrier firefighters and volunteer firefighters, or not even volunteer firefighters, were allowed. For example, Margaret Island was sealed off. I think it was the third or the fourth night, when the water levels were reaching higher and higher, and only a few carrier firefighters were allowed to stay there. Yes, I think I understand the question. The professional carrier versus the volunteer. Yes, we had this 10-15 years ago, that okay, this is my fire and that is yours. But do the citizens care who help? I think I would personally be interested in the quickest help and not the biggest help.
Yeah, and I think that's a good closing word. Sebastian is on there, so we should hand over to the next speaker. Thank you, Zsolt. Thanks for the questions.
Thank you. Bye.
Thanks very much, Zsolt, and thanks very much, Christian. It was very good to see this just-in-time training example for volunteers. And now it's time back to Olga to introduce our last speaker.
Yes. Hello. So it is my pleasure and the real one to introduce our next speaker, Elizabeth Benson. She's representing Innotis project, and I feel blessed and lucky to work with her. Elizabeth Benson is an inspector. She's a British police officer, currently serving as a head of performance and development at the UK National CBRN Centre, part of UK counter-terrorism policy. She's a qualified CBRN commander, tactical advisor, responder, and radiation protection supervisor. Importantly, she is part of a dedicated cadre of UK commanders, providing support to CBRN incidents throughout the UK. Her portfolio includes being the exercise director for national CBRN exercises, leading on the development and delivery of CBRN continuous professional development, and providing advice to UK government. Liz, the floor is yours.
Do you hear me and do you see me, Olga?
We hear you, but we cannot see you yet.
Okay. And can you now see me? Good morning.
Now it's perfect.
Okay, and now I share my screen. And is that acceptable?
Yes.
Okay, well, good morning. Thank you for the introduction, Olga. I will start and excuse me, I will read from notes. I want to talk to you today about a new form of just-in-time training, how to maintain response in a time of crisis by taking face-to-face training online. I'd like to tell you the definition of crisis. It's from the early 15th century, and a crisis is a decisive point in the progress of a disease. It's also a point at which change must come, for better or for worse. So this is the UK National CBRN Centre with office, classroom, training village and accommodation. A CBRN event in the UK is a terrorism incident involving a chemical, biological, radiological or nuclear agent, sometimes in conjunction with an explosive device. When CBRN, just-in-time training, went online, we had to understand what is lost when unable to do this established practice face-to-face. Is it the loss of the non-verbal communication or reduced confidence in the delegate by not having the opportunity to reach out and ask questions or clarify a point? Or for training on a practical procedure, the loss of the structure, usually balanced with the theory that reinforces the learning and assures us as assessors that delegates are competent in dangerous or critical safe systems of working practice. Today, I'm going to explain some ways the UK Counter-Terrorism National CBRN Centre transformed its educational structure to develop concurrent just-in-time training and critical function training at reach during a crisis. First, let me tell you more about the UK National CBRN Centre. We bring together the emergency services to protect and prepare the UK against chemical, biological, radiological and nuclear threat. We are part of counter-terrorism policing. We support the emergency services with 24/7 specialist advice. We strengthen the local and national response to a CBRN incident, and we assure and develop CBRN expertise in the UK and abroad. Chief officers from the police, fire and ambulance services lead the Centre's strategy in partnership with counter-terrorism policing, military and government. We recognise our best response to the CBRN threat must be through a united effort, with expertise drawn from the emergency services and beyond. The threat landscape is varied and sometimes rapid change can come fast. Whilst we must maintain strategic focus and manage longer-term projects, we also are reactive to changes in trends and technology. We work with partners to support and strengthen capability, to reduce vulnerability and ensure we, as the UK emergency services, are prepared. At the end of March 2020, due to the pandemic, our training centre paused its business as usual. we entered into a space where the priority was to look at critical training, recognise new training which had to be established to respond to the pandemic, and use new ways of working. We needed to keep pace with the national requirements to assure capability during and after the crisis. Today, my aim is to give examples of critical and just-in-time training and elaborate on how this was achieved during a crisis. How we plan, collaborate, and deliver. In crisis management, the event can bring together stakeholders and organisations who have no legacy of working together. Here, the situation, task, action, and result need a principle which is universally effective. We use a model and system which is accessible and wide-reaching. A model we use day in and day out, which is agile. And when it came to the new just-in-time training, it can be as relevant to business, industry, or partner organisations as it is the emergency services. The methodology I want to share and explain is the Joint Emergency Services Interoperability Principles. We call it JESOP. In the UK, JESOP is accepted and established practice for CBRN events. The joint operating principles and doctrine enhance the delivery of initial and specialist operational response. When our strategic direction came that certain counter-terrorism CBRN training must continue, it was imperative for the National CBRN Centre to use the principle and joint decision-making model to deliver this critical training at pace and online. This diagram is the joint decision-making wheel, and I am sure many of you are familiar or have a similar concept. This is more conventionally used at an incident scene or dynamically by commanders, not really to deliver training. The demand for counter-terror CBRN training to run concurrently alongside a pandemic crisis gave an opportunity to recognise this methodology for just-in-time training. Here on the inside of the wheel, you'll see it emerges. First, we start with the training needs analysis. What emergency services do well, and we all know this, is operate in situations of danger and risk. We do this by having safe systems of work, consistent commanders, and incredibly good training. The National CBRN Centre undertook a training needs analysis and fast-tracked the prioritisation of training through the relevant governance structure. Once the key training objectives were agreed, it was the team's moment to turn their face-to-face training into a blended online and in-person product. The training needs analysis identified certain priority training. I'm going to explain how a 2-day residential training course for a critical response capability moved online without reducing the content, tactical sensitivity, or quality of teaching. Here, our key considerations were the tight time frame and how to complement the arrival of some personal protective equipment that the training was designed for. We had the need to comply with social distancing and lockdown restrictions as far as was possible. We needed assurance that the full training would be delivered and ensure that the delegates were immediately deployable upon completion. And finally, confidence that the delegates would learn effectively using online training platforms. This was arguably the most ambitious part of the just-in-time training. As the world embraced Zoom or Microsoft Teams, the effort here was to find a consistent delivery platform across multiple IT systems across the UK. Options identified. A framework was designed to assist the team in evaluating the required criteria to select and develop the right online platform. Here, the chosen platform needed to perform against not only the training aims and objectives, but also against the legal assurance and policy stipulations. In other realms, online training is well used and an accepted methodology, and whilst always considered by us, it has been resisted for certain tactical training. Here, the joint decision-making model adds the contingencies in blue. A plan B must never be underestimated. Having the requirement to evidence the contingency is reassuring to all stakeholders. When the user requirements were met, the team worked with subject matter experts to ensure there was no dilution in content. As critical friends, we all assisted in taking part in a dry run practice. We used different devices, connectivity, and audio equipment. The feedback was used to improve the joining instructions, delivery, and content. Course face-to-face delivery. I am not going to explain the measures taken to provide safe face-to-face training. Suffice to say, we have all learnt a lot about administration, logistics, and how small our classrooms are. A 2-day programme was created. The online piece was the first day to allow reflective learning and consolidation to be in person on the second day. So here is what happened. Day 1, and we're online. Part 1, a test webinar took place to ensure that all delegates could use all the functions of the platform. All delegates took part. Then there was a break, which allowed for IT alterations. Then part 2, the full training session. This online training was live, interactive, made use of a chat forum, questions requiring individual response, learning video, and a plenary session. Day 2, and the team who had received the training on day 1 came to our centre. As low as reasonably practicable face-to-face training, used for certain tactical options, pertinent information, and confirmation of online learning. Results and review. Feedback and lessons learned. The first course returned 3 notable actions which were used to spin the wheel of the joint decision-making model. These actions were the new information that improved the learning within the just-in-time training. A point to note here is that the delivery of this training could not be 100% online. Certain information was delivered within the face-to-face training. There can be no lower trainer-delegate interaction with online training. Remember, online does not appeal to all types of learners. Delegates can be distracted when the trainer is unable to hold a room or engage with all participants. Here, the use of individual online participation and reward were a success. The trainers used a blend of poll, survey, and emoji to stimulate and gratify the delegate. That concludes my example of how the model underpinned design and delivery of the online training. A concrete example of just-in-time training in the UK is the pandemic multi-agency response teams. Here, teams were trained to respond to suspected COVID-19 deaths in non-medical locations in key cities in England. The specialist teams comprise of police officers, firefighters, and health service staff. The key objectives are to confirm life extinct, establish no suspicious circumstances, and assist with the removal, burial, or cremation services, and support the families of the deceased. The joint decision model was used for the training and delivery of pandemic multi-agency response teams. The situation needed skilled and resilient professionals with the correct legal powers and equipment, with the right transport and PPE to deal efficiently with the task. Training was delivered remotely using a novel presentation which delivered standard operating procedures, and pictorial direction for personal protective equipment and safe undressing procedure. The strategic direction to keep the balance between learning online and in person was defined as keeping all in-person training as low as reasonably practicable. This meant skills and drills were at reach, and personal interaction was used to promote the much needed responder resilience side to this task. The new teams of mixed discipline needed to trust each other for confidence and support during a difficult and emotive task. This blended learning was captured, and as the concept became a reality, the learning was shared and improvements were made to the procedures. My final opportunity here is to tell you about how the UK Counter-Terror Police Network is capturing the learning which has arisen throughout this crisis. Like all aspects of policing, we've had to adapt at pace to meet the challenges created by the pandemic. This includes adapting to new ways of working, be that remotely or by applying social distancing rules in the workplace. Despite these challenges, counter-terror policing has maintained pre-COVID levels of operational capability, and our nationwide capacity is consistently monitored to ensure the best possible protection against terrorist threat. Taking the time and energy to capture real-time learning whilst dealing with a pandemic is a challenge worth taking up. The value in sharing best practice comes when it saves lives or another person or department time or resource. For the Counter-Terror Network in the UK, the pandemic has given rise to manifold risk-based decision-making. Decisions which have been easier with the joint decision model and the joint understanding of risk through partner agencies. And here are my key takeaways. For online just-in-time training, virtual co-locating for training as mixed disciplines makes the communicating and coordinating a part of the responders' joint understanding of risk. Real-time learning must be fast-tracked through any governance structure and shared widely and in fast time. Have the trainer visible through as much training as possible, and at least at the start and end. It is a very good piece for engagement and confidence. Online joining instructions need to be as good, if not more so, than the traditional face-to-face instructions for attendance. Natural disasters, terrorist events, and public health emergencies will benefit and always have from just-in-time training. A key recommendation is to have the mechanism and understanding to make just-in-time training a key consideration to mitigate the harm and loss. When a situation requires a rapid change, the decisions made, rationale behind them, they need to be recorded. This is a key principle of JESSUP. I've just seen it in a previous presentation. I cannot advocate it enough. Capturing just-in-time training through online delivery allows responders the opportunity to revisit the delivery, and having a repository to store relevant just-in-time training is well worth considering. That concludes my presentation. Thank you for your time and attention.
Thank you very much, Liz. It was very interesting, very inspiring presentation. So you have a couple of questions. How many people have been trained through online just-in-time training?
From our centre, I think we've now done, we're on our 4th cohort of operating with those training principles. Slowly, we will be returning to the new normal, and the regulations are changing rapidly, but I think that blended learning will now stay with us. So as people have said, as devastating as the pandemic is, it has pushed us to really look at the application of online platform for just-in-time training.
Mm-hmm. Okay, thank you. Next question. Are there any considerations taken into account regarding security of online training events, about who is participating, watching, learning, taking into account that such trainings may be put in place for terrorism-related incidents?
Thank you. Somebody was paying attention there. I used cautious words because I work for the Counter-Terror Network, but yes, that is why not all our training can be online. We have parts which will always be closed within the network. What is on the online platform, we monitor by having email addresses that we identify as being secure email addresses. That's how we operate. There is the element of trust because that is our moral code of ethics, but also people sign in so we know who has done the training.
Okay, thank you. Next question. How do you ensure that participants have relevant background knowledge about the subject? And secondly, how do you ensure that the participant is the person she says they are?
Again, we had this discussion because for us, the online platform is something we had looked at and we had chosen not to do. So that was one of our concerns. It's a matter of personal integrity, and it did base on the email account which is assigned to the professional. So that was the starting point there. And then when they attend on the second day, they sign for their first day. And that's how we have balanced that out. And the question about do they have the skills, just in the previous presentation, yes, we have a national framework so we can see what skills people have so we are not inappropriately training.
Yeah, it's clear. Yeah, thank you.
Okay.
Do you train people from different countries?
Yes, please, my details are here. I mostly deal with the incoming and outgoing conversations to do with that, with our training department. But yes, we very much have it as part of our CBRN action plan going forward.
Mm-hmm. Okay, next question. Do you consider decontamination a topic that can be part of just-in-time training or something that can only be taught in face-to-face training?
I think it's not something we have covered, but I would be confident that just-in-time training online, as long as it was done with a shared situational awareness between all participants and that the joint understanding of risk was carefully delivered and discussed, we could do that online as multi-agencies. Obviously, there are some parts of decontamination which are very contextual, and that's where it comes to how we are much more comfortable at doing just-in-time training, often standing together where we can interact and sometimes role play through a situation. But I can see this advancing as we go forward. So decontamination would, for me, it would not cause an issue.
Mm-hmm. Next question. Who are the targets in this COVID case for online training? Firefighters, health services, or who?
Yes. Sorry, can you just repeat the start there, Olga?
Okay, I rephrase a little bit. So what type of disciplines of first responders are the audience of this online training in this COVID-19 case?
Thank you. So the online training that I first talked about and talked through about the day one and the day two, that's police delegates, and that's a police only tactic and operational part. The pandemic multi-agency, as I said, that's a blended amount of specialists to have the right powers and capability to deal with the aims and objectives.
Mm-hmm. Okay, and probably we have time for the last question. That was a general question for all, but I think you are exactly the right person to reply. Is there a legal framework for just-in-time training, and how the evaluation of just-in-time training is made or managed?
For us, our policy, doctrine, guidance in CBRN is largely overseen by our strategic leads and governance. We have the Office for Security of Counter-Terrorism within the Home Office, government department, and that's who I provide assurance to. So when we do just-in-time training, we really use our subject matter experts to critically look at what we're looking to deliver. And then it is for us to have the assurance and the recording of it as well, to go to the policymakers or the procedures and explain what we've adapted and how, and that's how we move forward.
Thank you very much.
Thank you, Olga.
Yes, thank you very much, Liz. It was really, really knowledgeable, very insightful presentation. Thank you so much.
Thank you.
Okay. So I guess we can conclude now our presentation. I would like to, yes, okay. I have to apparently scroll to my slides to the very end. To thank all the presenters, all the speakers today. It was very interesting, and I hope it was really inspiring, very interesting for all our guests. The discussions were excellent. Thank you for all your questions and your presence, your attendance. So for your information, all presentations will be available for download on the website where you registered for this webinar. So on the www.practitionersnetworks.eu in the presentations part, and the full record of this webinar will be also available there in the images. So you will see it all. For somebody who lost sound at some point or lost image, so you will have access to everything. And as the main outcome of this webinar, our 5 projects will produce a white paper with a webinar summary, key challenges, some summarized topics and discussions from all the 3 speakers, conclusions and recommendations. Of course, it will take us some time to prepare this, probably around 1 month or so, but all the participants will receive this white paper, of course, when it is ready. So we would like to thank you very much again. Hope you are with us now for all our further events, and don't hesitate to contact the relevant network of practitioners relevant to your field of expertise, to your interest, and we are always happy to receive you. Thank you very much. Have a nice day.